Audible, sir?
Yeah. Okay. Break in the audio.
Sir. Sir?
Is there any?
Sir, a little bit break, sir, but I think you can continue, sir. You can start the screen and you can share the screen and start speaking.
So, are you looking at the paper?
Yes, sir. We are able to look at the paper, sir.
Yeah. So, good evening, all my dear friends who have joined for this class on research methodologies. The aim of this presentation series has been that we do 3 classes of reviewing literature to get an idea of what are the terminologies that have been used and in what context they have been used. So when I look at literature, I look at papers which are one, trials, which we have seen the last week. We had looked at 2 trials and then one combined analysis of 2 trials and the results. So my highest piece of evidence would be the 2 trials or whatever trials that have been published. So we have seen what constitutes an ideal trial or an ideal paper. The second part of this series is going to look at multi-center data analysis and why that is important and what is the importance of building models, statistical models, especially when we are trying to prove or disprove TNM staging, why models are important. The next week's classes will be on systematic reviews and meta-analysis, where you would be able to understand what the findings are of a systematic review, what are the tests that are used in a systematic review and in a meta-analysis. And after the third week, we're going to start with our data analysis. The first class would be on glossary, that is, what are the different tests on SPSS. So we're going to start with simple retrospective analysis, namely univariate, multivariate, and then the fifth or sixth class onwards, we can think about data analysis in the form of models, statistical models. This paper and the next paper for this week's class is that this paper had changed the AJCC 8th classification system. Now, when you want to propose a modification for the AJCC stage 8, you've got to create a model with your new variable and prove that this new variable with your new statistical model is able to better predict outcomes. Now, it's not sufficient to create one statistical model. There are several authors who have published models that have been published to see which one best reflects the outcome of the patient. So this is an ICOR data set analysis where they looked at the data from different centers, and their hypothesis was that including depth of invasion in the T staging helped. So you can see this is a retrospective analysis. One of the strengths of having a multi-center data analysis is that you have a lot of patients, and even more important than that, you have a lot of heterogeneity. If you look at a trial which is carefully conducted with all variables carefully monitored, it is under a controlled environment. So the paper that you get from a trial has to be replicated in the community setting to prove that it is applicable to day-to-day patient that you're seeing in your clinic. The advantage of a retrospective, you have a large number of patients to analyze, and two, you have heterogeneity within the patient group, which will account for the heterogeneity that you will see in your day-to-day practice. So this paper had 3,149 patients in 11 cancer centers treated between the 1990 and 2011, and all patients had surgery plus adjuvant therapy. And I'd mentioned to you in the previous class, in the previous lecture, the ideal setting for a paper is that there should be a research question. The research question helps to further prognosticate T-staging. You should have an adequate sample size, which we have in 3,000 odd patients. Patients should be treated with the gold standard, that is surgery followed by adjuvant treatment, which have been treated here. And most importantly, patients should have a meaningful follow-up so that we can see the endpoints. And here the patients have been followed up for 40 months, which is sufficient for us to look at the endpoints. Now, when you look at the abstract, what did they decide to look at? They wanted to see whether there was any impact of depth of invasion on disease specific survival and overall survival in a multivariate analysis. So they found out that DOI was impacting the disease specific survival and overall survival. And there are some terms that you have to take into account when there is heterogeneity. This paper is a gold standard when you want to assess multi-institute. Want to propose a new staging system, this paper is a gold standard. So the first thing is that the institutional heterogeneity, that is between institutes, the patient variable, treatment variable, outcome variables, all were standardized using something called a two-staged random effect meta-analysis, which we will discuss as we go deeper in this webinar series. Found out the DOI cutoff. So DOI is a continuous variable. Patient can have 1 millimeter depth of invasion, 2, 3, 4, 5, 6, and thereon and thereforth. So they looked at the depth of invasion with the T category using something called the Akaike information criterion. And then they found out which model fit best using the Harrell in the fifth or sixth class of this webinar for you to better understand how these fit into model analysis so that you know which patients best fit into the model that you have proposed. So when they looked at their results, the mean and median are not important because you're calculating for the whole data set. So the mean was 12.9 and the median was 10 millimeters. But when they looked at different statistical models based on the Akaike and based on the Harrell's Concordance Index, they looked at different models, and the comparison models were the ones which have already been described in literature. So they looked at the optimal cut points and they found that 5 millimeter optimal cutoff point was good for T1, 10 millimeters was good for T2, and more than 10 millimeters was good for T2 to T4 category. And then they proposed a new criteria that if you have a patient who's got more than 10 millimeters depth of invasion, these patients will automatically go to T3. Now you look at the difference between what we discussed last week and what we are discussing now. The future isn't predicting models. You have to predict a model that best explains the patient prognosis, taking into account the variables that have already been published in literature. So in this paper, we have looked at the depth of invasion, which has been published in several papers by several authors, and they use the different cutoffs given by the different authors to compare with their model that they have created, and they found out which has the best fit. Now, this does not need to be limited to depth of invasion. This can be the grade of the tumor. This can be the lymphocytic infiltration. This can be the worst pattern of invasion. It can be any one of the pathological variables that have an implication in the outcome of the patient. So, this paper was looking at depth of invasion alone. So again, a good paper starts with a good introduction, starting with what the AJCC means, how the AJCC began. So they started by or the previous AJCC 7, and they've looked at all the papers that have supported the AJCC classification so far. That's how a good introduction begins. An introduction begins by solidifying whatever outcomes and whatever staging that depth of invasion does not feature in AJCC, but it features in other sites like cutaneous malignancies, and they want to find out whether the depth of invasion adds to a prognostic influence or adds to prognostic impact on the patients who have oral squamous cell carcinoma. So that is why the primary aim of the study was to modify the existing AJCC 7 staging, where they could incorporate depth of invasion, which was not there in the AJCC system. Best fit the outcome of the patient when you did a Cox proportional hazards analysis. So the aim of the study was to develop a modified staging system where they had incorporated the depth of invasion, and they also wanted to see if the heterogeneity between the different institutions had an impact on the prognosis, and they also wanted to see the prognostic influence of the current AJCC category with the previous proposed modifications based on depth of invasion. So that was their primary goal. And always the first table is the clinico-pathological demographic data of the patient. So here you can see that they classify the patients based on age, and that was fairly uniform, 27, 28, 24, and 19%. Predominantly it was male, but it doesn't affect, the sex doesn't affect the depth of invasion, so this doesn't matter that much. And when you look at the pathological grading, the T2 and T4 patients were higher than the T1 and T3 patients, and a majority of the patients were N0. And if you look at the category of the TNM stage, a majority of the patients quite acceptable and did not seem to have a bearing on the depth of invasion. So, when they looked at materials and methods, they looked at 11 comprehensive cancer centers worldwide. We had Tata Memorial from India providing them a large number of had 775 patients, and Taiwan had provided 1,219 patients. But these patients were all matched for their heterogeneity, and that's where the study went forward. The primary depth of invasion. And they found out that the mean depth of invasion was 12.9 millimeters, and the median was 10 millimeters. And as the DOI increased, there was a higher T category, a higher P category, and there was a higher extracapsular spread and involved margins, meaning as the depth of invasion increased, the aggressiveness of the tumor also became more, which was an important finding to remember. The other outcomes are not favorable. The other associated pathological findings also increase along with the depth of invasion. Now, they started looking at how to develop the model. Leaving aside all statistical analysis, they looked at the entire cohort, including T1 to T4 and all the depth of invasion, and they found out that the also said that after adjusting for T stage, N stage, adjuvant treatment, and the N treatment, the log transfer depth of invasion hazard was 1.31. So the hazard ratio had a significant impact on the outcome of these patients. Then they looked at other variables. The T category remained an important factor for disease specific survival, which we know because more the T stage of the patient, the less the disease specific survival is going to be. And the other factors also looked at the same features. Now, when they looked at the developing the optimal cut points, so meaning it has to be less than 5 more than 5, less than 10 more than 10. So you have to have a dichotomous way of separating the depth of invasion for each T category, but adjusting for the other covariates. And they found out that based on they used the Akaiki information statistic, and they found that the optimal cutoff points were 5 millimeters versus more than 5 millimeters for T1 and T2, and then less than 10 millimeters for T2 versus more than 10 millimeters for T3 and T4 disease. So all of the statistics we will cover in the subsequent classes, but this paper is a blueprint for you to understand what is the importance of the IKI information statistic in developing models. So this is how they developed a model. They had different data from different papers looking at 5 millimeter, 10 millimeter, 15 millimeters, and they found out that 5 millimeters. So this is the exploratory analysis. So what did they do? Once they had probable cutoffs, they had an exploratory analysis and candidate staging systems. They had 5 candidate staging systems to compare with each and every one. I would leave you to read the different staging models that they had made. So model 1 was a simple model for using DOI to define T1 to T3, and that performed poorly. And then the other models, model 2 was poor at differentiating between T1 and T2. Model 3 and 5 were designed to further stratify T1 and T2 tumors, but there was a lot of overlap. And T1A, T1B, and T2 for comparison to see which had the best outcome. They realized that the model which had the 5 millimeter cutoff performed best for specific severe disease. The model 4, if you look at the different models that have been proposed here, model 4 had the best percent for T2, 24% for T3, and 37% for T4. And this had given them model 4 was more informative based on the, so the lower the Akaike information criterion is, the better is your fit. So they found that model 4 was more informative based on the AIC. So if you look at, so this whole paper is that when you have a doubtful staging system, or when you have a doubtful pathological feature that you want to incorporate into your staging system, the first idea would be to look at retrospective analysis of how they have dichotomized pathological feature as yes, no, or 5 or less than 5 millimeters, or worst pattern of invasion as 2 or less than 2. While we will do an example of using AIC and Harrell's concordance in the 6th or 7th class of this webinar series, where I will give you a data set from the Amrita patient group, which are anonymized and which will not contain the entire data set. And we'll give you a mock data set where the equal number of patients are given to you with different T stages and different depths of invasion. And then we will come across different, we will create 4 or 5 different models, and then we will decide which model fits the best. Very difficult. It depends upon the cutoffs that have been set up by the previous retrospective analysis that have been described in literature, and it all to develop a new model. So statistical modeling is the future. You have to come up with new prognostic factors to incorporate into AJCC, and that will improve the prognostic discrimination of future AJCC staging systems. So the discussion is as we had discussed before, it has the same criteria. One is it has to delve into current literature describing the current AJCC staging and what were the proposed modifications to the AJCC system. They have mentioned that depth of invasion is an important factor to include in the AJCC system, but has not been done. And they also write that OS and DSS are significant when you look at DOI after controlling different other overall survival and disease specific survival. And they have also given the drawback. If the DOI has to be included in the staging system, it has to follow a standard measurement pattern. There are different institutions measuring DOI in different ways. So the paper has given you a warning that the depth of invasion has to be measured in a specified predetermined way. Otherwise, the depth of invasion might not be as significant as you think. However, the same authors of ICOR surrogate invasion is insufficient. The tumor thickness can be used as a replacement and will prognosticate the patient. This whole paper, whenever somebody writes a paper, whether it's a retrospective asked us to validate the results of their study externally. And we in Amrita have published 2 papers where we had validated the depth of invasion for T1 and T2 carcinomas, where most of the change has been recommended. And we found out that the DOI of less than 5 and 5 to 10 make a lot of difference in prognosticating the patient. And not only Amrita data, there's a lot of data published in the West where they have accepted or they have results which are on par with what the HiCor data set and the data model has prescribed. So this paper has everything that you need to know. There was a clinical question that whether they could improve precision of AGCC7 by incorporating another variable like the depth of invasion. They took heterogeneous data from 11 centers and 3,000 and odd patients. They formulated models based on different depths of invasion given by different people like Howard and Ewan, who had given different cutoffs for depth of invasion. So they created models for that, and they saw which model best fit with the outcome of the patient, and model 4 fit the best outcome of the patient. And they have told us that this data needs to be. And today, this depth of invasion classification has been included in the AJCC 8th edition staging system. So this paper I put across to you to understand the different steps of statistical modeling. So you have to learn what is AIC and Harrell Concordance Index. We will discuss this in the 7th or 8th class of our statistical analysis. But more in the end. The second paper that we are going, can you see the second paper, Bhargav?
Yes, sir. Yes, sir.
Can you see the oral oncology paper?
Yeah, we can see, sir. We can see.
Yeah. So the other important thing for you to remember is that any paper that has been published as a randomized controlled trial always has to be validated in the community setting. Any trial is done in closed circumstances with the best patient selection, best follow-up, and the best aftercare that you can expect a patient intervention. So last week we looked at two papers from Bernier and Cooper. Both were randomized controlled trials looking at what adjuvant treatment you have to give to patients with specific high risk factors, and a combined paper which I didn't send you across by email, but a combined paper which said that patients who have positive margins and patients who have extracapsular spread benefit by adjuvant chemotherapy. Now, this is a statement based on data from two randomized controlled trials, and the paper was published in Head Neck. Whether there is a survival benefit from chemoradiation versus radiation institutional data sets which are available are the SEER data set and the and their point was the analysis was not done separately for patients who subsite and HPV status. If you remember Bernier and Cooper's paper, it was all subsites and there was no mention of HPV as the etiological factor for the carcinoma. Patient who's not a smoker who has an HPV positive tumor tend to do better. But their data set from both Bernier and Cooper did not allow this and did not allow for stratification based on HPV positivity or not. So Ajmani and his colleagues from Illinois University in the United States looked at the National Cancer Database, where they had extracted 6,948 patients who were diagnosed of head and neck squamous cell carcinoma between 2010 and 2013, and who had surgical resection, and those who had ECS or PMS positive margin. And they looked at the effect of the adjuvant treatment on the overall survival using the Cox proportional hazards. Cox proportional hazards usually looks at the outcomes when compared to different variables in the patient. And they had done it after adjusting for clinical and demographic factors. And the results which they have presented in the abstract was that if you give adjuvant chemo radiation over radiation, there is a benefit for patients with ECS, but not with those who had positive margins. And in patients who had HPV negative tumors, chemoradiation was associated with the benefit of over RT compared to chemo RT in the setting of extracapsular spread. But however, patients who had HPV positive oropharyngeal tumors, patients who had HPV positive oropharyngeal tumors, CRT did not give any benefit with patients who had extracapsular spread, but was beneficial in patients who had positive margins. So there's a dichotomy here. Normally, as per the Bernier and Cooper analysis, you will give adjuvant chemoradiation to patients who had positive margins and extracapsular spread. But in a non-oropharyngeal primary, only ECS mandated patients to receive chemotherapy, and in HPV negative tumors, there was a benefit in patients who had positive margins. So now you see the difference. The difference is that the trial data presented one picture to you, but the trial data did not have any subgroup analysis or subtype analysis or any exclusion analysis. So this is why it is very important to take a trial paper, read the trial paper and its results, and then look for literature where the trial interventions have been done in the community setting, and we see the community data that has been published. Because in a trial you have the patients with the highest performance status, you have patients who've received the highest form of radiological intervention, it's a uniform treatment protocol thereon and therefore. So you have to always look at patients who had in treatment, the similar trial treatment in the community setting. So again, when you look at the introduction is very comprehensive. They've talked about patients who are locally advanced, patients who have extracapsular spread and positive margins, and also patients who've had adverse pathological features like perineural lymphovascular invasion. And these are patients who are at high risk. And we have data from trials to suggest that these patients may not only improve from adjuvant RT, but they also improve by adding the chemotherapy regimen in weeks 1, 3, and 5. And they have mentioned the two RTOG trials, that is the 22931 EORTC and the 9501 RTOG, which we had discussed in the last time. Both those trials had taken different adverse pathological features, and they had come to a conclusion that the chemotherapy added to radiation has a benefit. And then we looked at the combined analysis of those two papers where only ECS and positive margins were beneficial. And they also go on to explain why the trials haven't been comprehensive, where new observational studies have shown oropharynx behave differently from patients who have oral cavity tumors, and maybe we cannot add the same findings that we have found from the trial data to patients who have been having oropharyngeal carcinoma. So you look at the patient demographics. In the demographic data, you always have to look at age, sex, ethnicity. You have to look at the comorbidity. You have to look at the site of the primary. Here, it's oral cavity as the most, and the second is followed by oropharynx. That has been their entire discussion motto. Everything else, the T staging, the grade of the tumor, everything else has been accounted for. And they've also made sure that they have documented patients who have positive margins and patients who have extracapsular extension, because those two had a significant outcome in these patients. Now, if you look at the Kaplan-Meier curves, the Kaplan-Meier curve is a diagrammatic representation of the outcome based on a variable. And the x-axis is survival, y-axis is from time of surgery. You see that patients, the dotted line is patients who received RT, the straight line is patients who received chemoradiation, and the dotted yellow line is patients who have not received any adjuvant treatment. And you can find that patients who have received chemoradiation have better overall survival than patients who have received RT or no treatment at all. However, the curve separation is not very clear in patients who have had positive margins. And this is what we're talking for the overall group, especially with patients who've had oral cavity primary. So you can see that there is not much difference between the straight line, that is CRT, and the dotted line, red line, which is radiotherapy. There is not much difference between the survival and positive margins, and this was statistically significant. So from this graph straight away, we can make out that patients who have had chemoradiation, that is in the straight line, do better than patients who had radiation and patients who have not had any such treatment. So their study group was a lot of patients. 6,675 patients met the inclusion criteria, and 3245 had extracapsular spread, and 1496 had positive margins. And we also saw that with these graphs, we realized what the difference between giving chemoradiation for extracapsular spread and positive margin were. Now, the predictors of receiving adjuvant chemoradiation were patients who had ECS and positive margin received adjuvant chemoradiation, and the patients who had CRT were younger patients, and they had primary insurance. They were HPV positive oropharynx tumors, and those with high grade and pathological end stage. That was the group of patients which had the adjuvant chemoradiation. And if you look at the survival according to adjuvant therapy, when you used chemoradiation, it was associated with a survival benefit alone amongst patients with ECS, that is extracapsular spread, and the p value was significant, but not with patients who had positive margin. Now, this is very important because the combined analysis of Bernier and Cooper had said that patients who have ECS and positive margin benefit from adjuvant chemoradiation. And there are several studies in literature which have pointed out that if you have a positive margin, adjuvant radiation is sufficient and patients don't require adjuvant chemotherapy. So, this paper has said that if you have ECS, you give chemoradiation, but if you give chemoradiation to a person who's got positive margin, there is not much benefit with these patients. And that is the first outcome. Second is when they stratified HPV status. Now we know a lot of these oropharynx patients, almost 70% of oropharynx patients have positive HPV status. So they stratified survival analysis according to HPV status, and patients who had among patients who were HPV negative tumors and ECS, patients had a survival benefit over radiation alone in univariate as well as multivariate analysis. So it extended there also. So if you have ECS, patients had better survival with chemoradiation compared to radiation. And CRT was also associated with poorer survival to RT and no survival benefit in adjusted analysis for positive margin patients with HPV negative tumors. So it reflects the same thing as we had discussed before. And in patients with HPV positive oropharynx tumors and ECS, because in a HPV positive tumor, the nodes are likely to show more extracapsular spread because they are cystic nodes and they are large nodes compared to the primary. So the incidence of cystic nodes is much higher in a HPV positive oropharyngeal tumor. And this paper found out that in patients with HPV positive oropharynx tumors and ECS, that is when the tumor has breached the nodal capsule, CRT was not associated with the survival benefit even after adjusting for all the confounders. And patients with HPV positive tumors and positive margins, they benefited from the addition of chemotherapy or vis-a-vis no adjuvant therapy because that gave poorer overall survival. So this paper is important because we have distilled the results of the RTOG and EORTC trials and the combined data analysis to decide which patient benefits the most from chemoradiation. And we have found out that this benefit is different for patients who have oral cavity primaries versus patients who have oropharyngeal primaries, which are HPV positive. And these were not explored in the trials that have been done. So this is the advantage of doing a post hoc analysis or post trial analysis within the community with a large data set like the NCDB or the SEER data analysis, where the outcomes are real world outcomes, where the patient population is not controlled, the treatment is not controlled, the investigations are not controlled, patient selection is not very strict. These are the papers which actually reflect the impact of trial decisions in the public domain. So these two papers that have been presented today, one was for model building, which we will do in the 6th or 7th class of the webinar series. And the second is for you to understand the importance of population-based or large retrospective series analysis based on trial data and trial interventions. And this is how we make a decision for clinical practice. Merely following trial data might not give us the best outcomes. We have to wait for publications that have come out from large community papers or large population-based analysis before we can make a decision. I hope I've been clear in this presentation. Any doubts?
Sir, I think that's a great presentation, sir. I request everyone to please put your questions if you have in the comment section, please. Sir, as of now, there are no questions coming up. Would you
Yeah.
like to brief the what are the topics for our next upcoming webinars?
So the next webinar is going to be one paper on meta-analysis and one paper on systematic review with all the statistical tests that have been planned in either of those two papers. So I will send two papers across, and that will be the last paper discussion schedule for this webinar. And from the fourth class onwards, you will start with univariate analysis. That is the terms used in univariate analysis, the test used in univariate analysis, and so on and so forth. So the next class is going to be the last one on paper analysis, descriptive paper analysis, where we are going to look at univariate and multivariate analysis. And that will be on two papers.
Okay, sir. Dr. Dhruv and Dr. Shubha, we will, as soon as sir gives me the papers, I'll forward them in our group and in our
Yeah,
Telegram group also.
yeah. So the plan is from the fourth class onwards, there'll be a glossary where the test that we are going to do is going to be first explained to you in non-mathematical terms. So we will focus on 3 tests to 4 tests every presentation. And what is the meaning of these 3 or 4 tests? What is the context and how to interpret the results of these 3-4 tests? And then we will run them on the data sheet that we have. So we are going to do that for 6 or 7 classes after that. So the survival analysis will be the last 3 classes. Before that, we'll focus on univariate analysis. Yeah,
Okay, sir. So,
yeah,
as of now, I think that's the end of our session, sir. So, with
yeah.
this, we will take a leave for today and we'll regroup on the next webinar session.
In 2 weeks from now, that is correct.
Yeah.
Thank you all for your attendance.
Sir, there are few questions coming up,
Hello.
sir.
Hello, sir.
Yeah.
Deepak,
Yeah,
sir.
yeah,
Sir,
yeah,
sir,
yeah.
just one question which has just come up, sir. How to get cut off more than two in continuous data statistically?
We will discuss that when I talk about continuous variables for data analysis. So we have a class on nominal data, ordinal data, continuous data, and we will discuss on how to come up with cutoffs either by minimal p-value or by Cox regression model. We will discuss that. It's a statistical test. We haven't reached that level in our discussion so far. So when we come to continuous variables, I will tell you that.
Oh, okay, sir. And so I am just putting up the uh, uh, Telegram's link in the chat box. So for all the people who want to get the updates as well as the search next data, kindly follow this group.
Yeah.